The last section's about cardiac arrest. This is a brief section for suspected COVID-19 patients. To resusc or not is question one. Is in a pandemic, and you have to remember that most people who have cardiac arrest die, right? And they don't have a successful outcome. And a successful outcome is leaving hospital neurologically intact with minimal disability, or mild disability. And so most people don't have that. And if it's out of hospital, very few people have that. So exposing the risk of staff to COVID for a highly unlikely successful outcome is generally not wise. So you have to decide based on all the factors that you could consider, decide on viability, as some of them are mentioned there, to whether to actually do the resuscitation or not, is question one, or whether to call it at the door, for an out of hospital, or not even start, depending on all the situations. But if you think it's quite survivable, then generally we should resuscitate. Assessing response, shaking and shouting is okay, but when we listen for assessing breathing, we listen and feel. Sorry, we don't listen and feel. We just look for signs of breathing. Don't bring yourself close to the patient's mouth. And you have two effective alternatives about PPE from the guidelines. One is that you don all your tier 2 PPE, because there are going to be aerosol generating procedures, so aerosol to airborne PPE, before you come near the patient, which can take some time, which is a real downside for the patient. But like a lot of things in this pandemic, there are lots of downsides for being a COVID patient. And you got to protect all your staff. But the other option, which has been suggested in the ILCOR guidelines, is defibrillation seems to be fairly safe. There isn't a lot of data suggests that causes really any or much aerosolization. If it does, it wouldn't be very far from the mouth. And so they're suggesting that you can attach pads, assess the rhythm, and if it's shockable, defibrillate them before getting into PPE. And so again, it's for you and your colleagues to decide what you do. But it's not an unreasonable compromise where you think you might have a shockable. This is for your in-hospital cardiac arrest, obviously, for those of you who are working in a hospital, that you would pop the pads on, put on the defib, bring the defib as far as you can away from the patient, and then if it's defibrillatable, defibrillate them. And then if after that one shock, I would then be putting on PPE either way, because you either got ROSC and then you're going to do all sorts of aerosol generating procedures on them, or you don't have ROSC. Either way, you should be putting on PPE and starting your process. And then the alternative to all that is you don't do anything until you've actually put on PPE before you go into the patient. So it's your choice. These are the options recommended. Other considerations: minimize the rescues in the room. So usually with the resus, you have like every man and his dog and their dog's friends as well in the room. But in this time, it's only the people that have to be in there and rotate to 3 CPR. Again, ideally negative pressure room, compression only CPR, no ventilations. For the first few minutes of a rest, that's actually all that you need anyway. And if you have a mechanical CPR, or you can get one from your ambulance colleagues, use that, and then no one has to do CPR. But now, if you decide that you are going to ventilate them, that you are going to try and ventilate them, like they might be survivable, or they had a hypoxic arrest that you witnessed, then you need to really ideally get a tube down, because an ETT is the only thing that is closed circuit. So I'd put in, if you can, get an ETT in, and when you have to stop CPR. So unlike normal CPR, we actually stop CPR to get the intubation done, because you can expose them to aerosols by doing CPR while they're intubating. Intubate them, cuff up. Once you've got a closed circuit, then you can do your ventilations as well. And the next best thing is the LMA, but there is some leak in there, so that is going to be aerosol generating. And the worst thing is the BVM, because there'll be more leak. So that's it for CPR. That's it for our night. Now it's time for those who want to sleep, and those who want to ask questions to hang around. I'm going to go through any questions you have. And Sharon's going to send you all out feedback forms. This is the first time we've done this. And I hope it's been valuable for everybody, and it's been a way that we could give you guys good information during this pandemic when we can come out and see you. So thanks to everyone who came, and let's talk about questions. So I'm I'm trying to see. So someone don't know the Menagerin only have video laryngoscopes. Well, that's good because that's what I would use. I thought the COVID patient didn't initially present with ARDS lungs. They should not be stiff lungs to ventilate. That's correct. So that's the L-type patient is what we believe. Okay, yeah, so question here from Jonathan. If you have only maximum of 3 person in the room, what if the COVID patient goes into cardiac arrest and needs resuscitation during intubation or at any time? Do we need to allow more people inside the room to help with CPR? And do we have any ALS modifications? Well, I've gone through all the ALS modifications. What other things can you do? Great question. The only person who can come into the room to join your 3 people is the person in the anteroom. So remember, you've got 3 people in the main room, then you've got 1 person in the anteroom, and that person's in full aerosol generating PPE, and then you've got a clean runner. So that's the dirty runner. Then you've got the clean runner outside the door, who's completely clean. That person cannot come in. So only the dirty runner can come in and bring in whatever you need to bring in, like the defib. And once you're in, you're in. And that's it. It's the 4 of you for the CPR, and which will last as long as you think viable for that patient. So that, I hope, answers that question. It's going to be a maximum of 4 people. Any thoughts on the risk difference between ETT, supraglottic airway? Yes, ETT is better. And supraglottic airway is going to aerosolize bugs because there will be leak. It might not be a lot, and it's better than a BVM. So if you get one in, if all you can get one in, well, that's something. But you are going to have leak. So it's not ideal. So if you can get an ETT in, it's better. So this is one of the situations where we actually do really want an ETT in if we can get one in. So that's important. The other thing is, if you're using it as a rescue device during intubation, when you put an LMA in, it's going to be a good seal. But then when you pull it out, you're going to pull out this, wet, COVID-covered LMA. So unless you have to, I wouldn't put an LMA in. I'd just be using my BVM and then putting my tube in. And I'd only put an LMA in if I could not actually ventilate them with a BVM. So someone asked for the COVID intubation checklist at Helen. So yes, of course. Yeah, I'm not sure where you are, but
it's been distributed through REOC.
It's been distributed through REOC. So it's a wax one, is it? Or Wheatbelt one. Okay. So yeah, Wheatbelt REOC.
If anybody who wants any of this information can email me, and I can.
Yeah. So that one, just get in contact with Anna Peroni, who's the clinical lead for the Wheatbelt, and she can get you those things. There are some good ones online. Safe Airway Society has one in their guideline. Scott Weingart at MCRIT has a very, very detailed, every single step possible is on the list. So it's quite good because they just go through every single step. And both of them are going to add on to the ED Guidelines website in the next few days in that guideline. Another question, are all unconscious on arrival patients considered COVID-19 suspected patients? Good question. All these things were things we were maybe doing a couple of weeks ago, but now we basically have no COVID-19. So, we've got so little COVID-19 that if they haven't been sitting in a hotel room for the last 14 days isolating because they've come from overseas, or they're not a known contact, or they're not on a cruise ship, then they almost certainly don't have COVID. So all the things that we were doing 2 or 3 weeks ago, we're probably going to stop doing. And I think it'll be a great tragedy if now, we have an APO patient who comes in the middle of the night with classic Bando APO, and we, all decide to, get a full PPE on and don't put them on CPAP and put them on non-rebreather, and then they just die. That would be a disaster, given that we really don't have much COVID anymore. So we all have to realign what we do now, knowing that we're close to getting rid of COVID from the entire state, and think carefully about how we approach our probably non-COVID patients. It's all difficult. We've got no easy answers, but those are the things we have to think about now that we're very lucky that we're getting close to getting rid of COVID. So I think that's covered all the questions, but if there's any others, shoot them through in the next, now. And if I don't see any more questions, the rest of our team are going to sign off. Thanks to everybody who, Fiona, Gavin, Anna, who and Maddie, who jumped at the end, I think that's all. Yeah, look forward to getting your feedback forms. When you send them in, you will get a copy of the slides, and I'll put a copy of this talk up on a website, probably the ED Guidelines, and send you the link so you can watch it again or refer it to colleagues who'd like to know about COVID at 21st of April, which might be different to COVID at 1st of May, but who knows? Yeah, that's right. Great. Thank you for all the comments and thanks. It's very much appreciated. I will shortly, I will mute now.